Hello and welcome to another episode of the Health Notebook. Today we have Dr. Hansrod in the studio. She's a psychiatrist and we're discussing depression. Dr. Hansrod, welcome.
Thank you for having me, Ziyaad.
Dr. Hansrod, can you just tell us a little bit about yourself?
Well, I grew up in a small town called Mokopane in Limpopo, and I did my undergraduate degree at Medunsa and my postgraduate degree in psychiatry at Stellenbosch University. I am currently practicing at Jukai Malomed in Retreat.
Okay. So that is in the southern suburbs. Can you just tell us a little bit about the services that you provide?
Well, you know, we see, because I'm a general psychiatrist, I see all kinds of psychiatric illnesses. The clinic itself is geared towards seeing more patients with anxiety and depression, as well as trauma-related illnesses and adjustment disorder. But I myself would be willing to see any patient with a psychiatric illness.
Okay. Do you treat adults as well as children? Or?
Look, with children, it's a very specialized field, so we prefer to get them seen by a child psychiatrist, but I do see adolescents above the age of 13 and the elderly people as well.
Okay. Now, can you just explain to the viewers the difference between psychology and psychiatry? There is this constant confusion. Can you just be able to differentiate that?
It's common, and it's understandable that people get confused. With psychology, it's very much more therapeutic based. There's different therapeutic modalities that they work on. With psychiatry, we're very much more biologically based, where psychiatrists would have studied medicine before, would have practiced as a doctor and then specialized in psychiatry, and we're able to admit patients as well as prescribe medication to patients.
So you spent an additional 4 years specializing in psychiatry.
Yes.
Okay, can you just explain the basics of psychiatric, a simple condition such as depression? And we have various different types of chemicals in the brain. What actually happens when one develops depression?
With depression is what we call a mood disorder. So with depression, people experience symptoms such as a low mood or irritable mood. They would have changes in their appetite, insomnia. Some people experience guilt. Some people then low energy, poor concentration, anhedonia, which is a lack of interest in pleasurable things. Then sometimes they notice some physical or motoric slowing as well. Some people experience suicidality. Depression, the causes of depression are varied, and look, having a family history of depression does predispose you to developing depression. Some neurochemicals in the brain, abnormalities.
So those are the risk factors that places a person at additional risk to depression. Yes. Okay, so you mentioned a family history. What other risk factors?
Well, other risk factors, look, depression is more common in females, in people with poor socioeconomic circumstances, and people who have previously had depressive episodes. So those people are more predisposed to having depression. Okay,
what about postnatal depression? Where does that fit in?
Well, with postnatal depression, look, it occurs in women in the postpartum period. It shouldn't be confused with postpartum blues. Postpartum blues are a milder version of the symptoms which lasts for a definitive period of time, whereas postpartum depression can last for a much longer period of time, can affect the person's functioning, and it can be much more devastating to the mother themselves as well as the child if help isn't sought.
Okay, and how common is depression in South Africa?
It's quite common in South Africa. From my understanding of the literature, it's possible that it's prevalent in 10% of the population to some degree.
Okay, so you've mentioned a little bit about the causes of depression, but can depression occur simultaneously with another psychiatric disorder, or does it just occur individually?
It very commonly occurs with people who have anxiety. You can see depression with multiple other illnesses, people who have ADHD, attention deficit and hyperactivity disorder, people who have a history of substance use. So yes, it can occur with other.
So it can occur simultaneously. Okay. Okay. Going back to the symptoms, can you just highlight again, how would I know if I have depression? So what are the symptoms?
Well, look, with the symptoms and signs. So we would have low mood or irritable mood. Okay. So that would be something that you would see in every patient. Then, like I said, you would have significant weight loss, insomnia.
So when you mean insomnia, what does that actually mean?
Difficulty either falling asleep, staying asleep, or maintaining sleep, falling asleep, or people who have abnormal patterns of sleep, basically, where they have less than the amount that they actually need to feel rested. Okay,
so how does this actually affect your daily functioning? I mean,
depending on the severity of your illness, this can affect your life throughout your life. Basically, your work functioning, your home functioning, performing your normal role in your family can also be affected. So yes, it can affect every aspect of your life.
Okay, so that would mean that if a person is depressed, it might affect his or her productivity at work.
Yes.
And if the person is not managed accordingly, then, or if they don't receive treatment, the person can basically lose his or her job as a result of poor productivity, and the main cause being depression.
Yes, because you get low energy, you get poor motivation, you get low concentration as well. So these things affect your productivity at work.
Okay. Now, one normally looks at the person and we say the person is depressed, but how does that affect the rest of the family? Can you just,
Well, look, with depression, depending on the severity of the depression, with patients with moderate to severe depression, this can really affect the family profoundly. I mean, with regards to the partner, there's changes in the way the person interacts. The people become more drawn. The irritability can affect the way in which the person interacts with their partner. With regards to children, the care of the children can become neglected due to the fact that the person has low energy and low motivation. So it really does affect the family and puts a high burden on the family, as well as the fact that, I mean, this person will not be contributing in the workplace as well. So from a financial aspect, this does become a problem.
Okay, so you've spoken about the signs and the symptoms, and you've given us a little bit about the risk factors. Yes. Now, let's assume you have a patient, and how do you confirm the diagnosis? Now, you have someone that says, I have A, B, C, D, E, F, G. What's your next step in the process?
Look, I mean, we like to look at the history from the person, look at firstly, the symptoms. Do they fulfill the criteria for a major depressive episode or disorder? How severe are these symptoms? How significant do these symptoms actually impact themselves, whether it's at work or be it at home?
Okay. So when you mean about criteria, are you meaning the Dsm criteria?
Yes, the Dsm criteria, which are the signs and symptoms that I've highlighted previously, that I've talked about previously. Yes, those are the Dsm criteria. And the way in which we classify whether someone actually has a mood disorder or not is that we look at whether the person has a presence of 5 or more of those signs and symptoms that I previously mentioned.
So mood disorder is not just depression, there are other illnesses that is classified under mood disorder. Okay, so what are the other?
Well, we're looking at major depressive disorder, we're looking at bipolar disorder, we're looking at dysthymia, cyclothymia. Those are all different mood disorders.
Okay, so you've mentioned 4. Can you just elaborate maybe on bipolar? What is bipolar?
Well, bipolar disorder is a disorder that is characterized by a person experiencing mania, which is euphoric or irritable high mood, as well as depressive symptoms. We get 2 types of bipolar disorder, bipolar 1 and a bipolar 2. The bipolar 1 is characterized by mania and a very high with or without the presence of depressive episodes, whereas bipolar 2 we get a hypomania, where it's not as high as a mania, but the person still experiences either euphoria or irritability, but there's definitely depressive episodes that are present.
Okay, so it's a high and a sort of a low type, so it cycles in between.
Cycles.
Okay, and then you've also mentioned dysthymia.
Dysthymia is a presence of a low mood, which is constantly present in the person. So the person will feel low for more days than not, basically will have a lowish mood for more days than not.
Okay, so from there you've taken the history. When do you diagnose? After how many weeks? Do you recognize a particular pattern? Is it happening once every 3 months? Is it just one brief episode? Is it there for 6 months, 9 months, or what's your classification?
So with the classification, we look at symptoms being present for most of the time for a period of 2 weeks.
Okay.
So it must be present for that period of 2 weeks.
So that is defined as a depressive episode?
And it's defined as a depressive episode, and if the person has 2 or more episodes, we call that a disorder.
So it becomes a depressive disorder then?
Yes.
Okay. So now, when you've taken the history, the family history, are there any blood tests that needs to be done or to exclude other conditions?
Yes, because with the causes of depression, it isn't just the family history. We also have chronic medical illnesses that can give a person depression, as well as hormonal abnormalities such as thyroid problems, low estrogen, increased cortisol levels. Those things can also lead to depression. Some medications can give a patient depression as well. So we need to look at all of those. So we need to do blood tests to determine that this is not a medical disorder causing this depression. And we need to rule out some of the chronic illnesses as well.
So that is part of your screening process that every psychiatrist would do, followed by a medical examination as well. Okay, so now you've been diagnosed with depression. Are you just going to give me medication? Can you just even, can you tell me a little bit about the medication?
Look, as far as depression goes, it doesn't always mean just because you have depression that you've got to be on medication. We need to look at the grade and severity of the depressive symptoms, and from there we choose the management appropriately. With mild depression, we look at more of a therapeutic management. We might look at interpersonal therapy or cognitive behavior therapy, so some form of therapy, and if the therapy is our first line, and then perhaps medication is our second line. With moderate to severe, we would look at possibly combining therapy as well as medication. So with psychiatry, we like to do more of a holistic management.
So that would be the therapy combined with the medication?
Medication, but we would also like to look at the social aspect of the patient, because it's very important to get good support for patients with major depressive disorder, that they don't feel so alone, so isolated.
Okay.
So what we do in psychiatry, we call it the Biopsychosocial Model. So we look at the biological with the medication, the psycho with the psychological interventions, and the social with the social interventions. So more of a holistic.
So you involved in a multidisciplinary team then?
Yes.
Can you even just highlight or elaborate the types of therapy? You've mentioned therapy, but are there any subtypes of therapy that is used for depression, or what's the objective of the therapy as well?
Look, the objective of the therapy is to teach the patient ways in which to cope with what's happening around them in the environment.
So coping mechanisms?
Coping mechanisms, as well as interpersonal skills as well, so they can better relate and communicate with the people around them. And reach out when they need help. Learn to communicate with their partners if they're having difficulty with their partner or with their children, at work as well, so that we can try and help them to function better.
Okay. So it's equipping them with the tools necessary to control their thoughts, how to engage with issues in their daily lives. So that is actually provided with the group therapy.
Yes.
But the group therapy, as I understand, is not only for the individual, but it's also for the family as well.
Yes, we do have family therapy. We generally try to, it's dependent on what problem the patient's having. If the problem is related to the family, or we feel that we can find a solution with in the unit, then we would do family therapy. We don't necessarily do family therapy for every patient.
Okay. Now you've mentioned a little bit about the medications, and you've also classified the depression in mild, moderate, and severe. Just tell us a little bit about the medication. When does it start to work? If I take the tablet today, do I expect to feel better tomorrow, or how does that actually process work?
No, look, if you, it's decided that you should be on medication, it generally takes about 4 to 6 weeks before you really see changes happening, where you might notice a bit of increase in energy, decrease in anxiety, and lifting of mood as well. Okay. So you do need to continue it for about 4 to 6 weeks.
Sometimes I might even feel worse during the initial period, and then afterwards it will gradually stop.
You're very right. Usually with the antidepressants, you can feel slightly more anxious or even irritable or experience side effects in the first few weeks. So that's why we always advise our patients, look, you need to know, you need to arm yourself with information. You need to know what the side effects are. You need to know what process you're going to be going through while you're on this medication. So it's always important to educate them about the management before you put the patient on, because you'll find that if we don't educate a patient, 1 week down the line, the patient might experience side effects or might be feeling anxious and saying, they'll call you and they'll say, but doctor, this medication's actually made me feel worse than what I was feeling.
So let's assume the person says the medication is making them feel worse. They then decide to stop it and they don't follow you up. So part of your management is actually also follow-up care.
Yes, no, follow-up care is very important to us, but the problem is, it's always important to try and build trust and keep the trust from the initial time when you see the patient, as opposed to, having that problem where the patient doesn't want to come back to you or doesn't want to come back for follow-up with you. So it's very hard once you lose trust of a patient to actually try and get them back to come and see you again.
Okay, and once I'm on the medication, right, so I know each case is individualized. Do I need to remain on the medication for the rest of my life, or can I go off it at some stage? Because most people think once they're diagnosed with a psychiatric illness, it's permanent, but I think that's the wrong perception.
Yes, absolutely. Look, when it comes to with major depressive disorder, generally in the first episode, it's recommended that you continue medication for a period of 6 months and then slowly taper and monitor the patient. Taper off the medication and monitor whether the patient, will be needing to continue medication, or we can safely discontinue medication. When they have more than one episode, it's recommended that they continue medication for a period of at least 2 years, and then we should try and taper the medication and monitor them. There are patients who have the need to be on medication for longer periods of time, because you would then notice with these particular patients that once you start to taper down the medication, the symptoms start to come back up again.
Okay. And people on the medication, they function normally afterwards. Once they start improving, so they can go back to their normal functioning level. Is that?
Yes, that's absolutely correct. Once the depression has been treated, patients generally go back to their normal functioning and their normal roles within the environment.
Okay, just going a little bit back, when we spoke about the postnatal depression, yes. Just give us the signs and the symptoms of postnatal depression. Does it fall, or does it appear similar as the normal depression, or when does it occur? Just a few days after?
It would occur about 7 days after the woman has delivered her baby. And yes, the symptoms are very similar to depressive symptoms, where you have changes, you have mood changes, you have changes in sleep, changes in motivation, energy, appetite. You see all the changes that would generally happen in a depressive episode. The biggest problem that we have with postpartum depression is that a lot of the symptoms often are very similar to what women experience normally after they've delivered a baby, where you're tired, where you might be a little bit irritable, because the baby is waking up in the middle of the night, you haven't slept much, you haven't been eating properly. So it can sometimes seem as though this is something normal, but once we start to notice that there's dysfunctional or poor functioning, where the woman is unable to perform the role, or the person is unable to perform the role that they need to perform, then we start to get worried.
Okay. So when you mean unable to perform the role, I mean, I know it's with the newborn, so what do you mean?
So poor self-care, neglect of the child, not washing the child, not cleaning the child, literally just neglecting themselves and the child. Sometimes the person might experience suicidality, they might experience psychosis. So those are obviously the more extreme versions, but you will see definite abnormalities in comparison to what you would expect from a normal postpartum woman.
Okay, so what should be done then at that stage if the person, so if the person is unable to see that they are functioning below that particular level, what should be done? Should a family member try to get involved? Or
generally, we find with patients with postpartum depression, the family members do note. Look, you'll see either the mother or the partner, or someone will say, "Look, this is not right," or the woman themselves will say, "Look, I'm just not coping, and this just doesn't feel okay to me." And a lot of times, these patients are then taken to the GP, who will then refer them on if they think it's postpartum depression.
Dr. Hansrod, we've reached the end of the show. Can you maybe just give the viewers a take-home message on depression?
The most important thing I think with depression is that if you do feel that someone you know or you yourself are depressed, seek help early. We can try and facilitate appropriate management so that you can function better and feel better.
Dr. Hansrod, thank you very much for coming to the show today. It's been a great pleasure, and we hope to see you soon. Thank you very much for watching. Stay tuned for another episode next week, same time, same place.